So good evening to everyone who's already joined. We're just waiting for another half minute before we start the presentations and the introduction.
Okay, Sybille, I think we have over 70 already, so
yeah, we start.
You could probably make a start.
Okay, good evening, everyone, and a very warm welcome to all of you joining us tonight for the first FESSH Academy webinar after the summer break. We're delighted to restart the series with today's event, which is kindly hosted by the French Hand Society, Société Française de la Chirurgie de la Main. Sorry for my French. The topic could not be more timely than microsurgery's place in 2025. So microsurgery has always been at the heart of hand surgery. So tonight we will hear about where the field stands today and how it is evolving for the future. Let me briefly introduce the program. We will begin with an introduction to the French Hand Society by Professor Sybille Facca, who will also speak after this introduction about microsurgery education in 2025. And then we will hear about a special microsurgical technique, a free toe transfer. And we will finally hear Kursat Erdogan, who will present a new Nervix nerve tube for protection and regeneration of nerve surgery. So after these lectures, we will open the floor for a lively discussion with our distinguished panelists. We have also Dr. Guillaume Bacle and Nicolas Bigorre, as well as our speakers to answer your questions from the audience. So tonight's session will be chaired by the chair of the Education Committee of the FESSH, Jonathan Hobby from the UK, and myself from Germany as a co-chair. So before we start, let me thank our French colleagues for hosting tonight's webinar and all of you for joining us in such a great numbers. It is wonderful to see our community back together after the summer break, ready to learn, exchange ideas, and maybe also inspire each other. So with that, I'm happy to hand over to Sybille to start the presentation about the French Society.
Thank you, Elisabeth, and hello, everybody. So I will start with a presentation of the French Hand Surgery Society, and then I will introduce, after my topic about microsurgery education nowadays. The first colleague is Dr. Germain Pomares from Luxembourg, and he will present you a free to transfer in 2025. And then Dr. Kursat, who works in Strasbourg too, he will present Nervix for nerve protection and regeneration. And then we have a discussion about the different case report, and the animation will be done by Professor Guillaume Bacle from Tours. So let's talk about French Hand Surgery Society. I am the FESSH delegate of this society. I am a professor in society and the chief of the department of department in Strasbourg. The French Hand Society was created by five famous surgeons in February 1964. It was the beginning of GM, Groupe d'études de la main. It means it's a group of hand study. So these people was Dr. Toubiana, Duparc, Michon, Villain, and Rabichon. Two years later, we had 24 members, and 10 years later, the society changed the name. It was SFCM. It means Society of the French Hand Surgery. Nowadays, we have 725 members. So this is the board. main board, we have some people more like me, and the president is today Professor Aubert from Besançon. The next president, it will be Professor Okit. It's a plastic surgeon in Rouen. Next one, Dr. Boubier from Paris. The past one, it was Professor Chamas from Montpellier. And we have also General Secretary, Dr. Geano, and the people who help him, Dr. Grafio from Strasbourg too, Dr. Zemerlin, the treasurer, and the secretary, Miss Juliette Short. We have, concerning the organization, a lot of commission or committee, and especially we have a relationship with another society, French society, about education. And we have also a journal, of course, a review for our article. But nowadays, our publications are in English, not in French. And we have really commission for the juniors and for education, choose the publication for the Congress, because we have a lot of events, and especially we have the national event each year in December in Paris. And this year, so Professor Aubert will organize a Congress, and the topic will be the mistake in hand surgery. We have also small events like this month in September, something about organization of emergency department for hand surgery. And me, I use also to organize a cadaveric lab in Strasbourg for young surgeons, so in October. And you have also famous course in Luxembourg now 2 times by year about flap, and also in cadaveric lab. So we use to participate to FESSH events, and the team went to Helsinki in last June, and we will organize the French Answer Society with Strasbourg team, the FESSH in 28th. So you can find more if you want information on our website. We have each year a little book to explain every activities, and so also you can ask me a question by mail or no if you have a question about our society. So thank you.
So thank you very much for this interesting introduction. And now we are excited for your next talk, what microsurgery's role is in 2025.
Okay, so let's move to this topic. So I wanted to speak about teaching microsurgery, because I use to manage a diploma of microsurgery in Strasbourg University with also Dr. Erdogan and Professor Sybille, a few or many years now. About teaching microsurgery, you know that we need, of course, microsurgery like other specialties of surgery. And of course, at the beginning of education. We need to offer to students good tools and easy techniques and also cheap techniques, but we have to continue to change and to use modern solution. And now we have a lot of digital tools to propose to students, because microsurgery it's not a whole technique. We have a lot of innovation, and especially for microscopes, because now you can have 3D vision, magnification until 20 times. You have robotic, of course, with different arms. Endoscopic is possible, and you have also different kind of simulators, and the digital tools also is very useful and possible. And you have new things. It's just an example, because you have, of course, more innovation in our practice. But with robotic, you can avoid a big incision if you do endoscopic, for example, to take costal nerves for graft. And so you have to learn a little bit of robotic surgery, from microsurgery, to your student. In France, we use a lot surgeons the robotic, and in fact you have several arms. The surgeon have only 2 arms. You will avoid the tremor, and we know that we will improve the precision, and also you will have a rapid learning curve. And so we test. It was good with 2 robots to make reimplantation of limb of pig, and also we use on human to make nerve transfer. And now you have 3 hospital in France. They have the robot Simani, and they use them for super microsurgery on human case. So to go back to learning, of course, in France, the particularity is that we have a diploma. And we have a lot of students from all over Europe who used to come in France, because of course, they want to learn microsurgery, but at the end, they want to have a diploma. So we have a lot of teachers from different specialty, but mainly it's orthopedic and plastic surgeon. And in France, we have, you see, more than 2,000 students. And so not only surgeons, but neurosurgeons, pediatric surgeons, they need to learn microsurgery. But we have a lot of problems, and especially for management of animals, and because of regulation, the European regulation is difficult, more and more difficult, and we have problem to find monitors and to buy fed animals. It's not so easy, but we try to continue to learn microsurgery. You have to remember that you have 4 levels for learning and training microsurgery. The gold standard is with the rats, of course, and because it's a living model. But as I say, it's more and more difficult, and we have to reduce, to replace the rats, and probably after 2030 in Europe, it will be very difficult to continue to use the rat model. The level 1 is the digital model. It could be expensive, but now some industry try to develop cheapest model, and we use a lot, and especially for beginning models from level 2. It's non-living model, and the level 4, it's the last model with a complex procedure like a flap or a limb replantation. So I will show you a few models of level 2. The most famous and very useful is the Japanese nodal. We can use them in oral because the nodals are sterile. Of course, you have to prepare them, and especially if you use them like vascular model, you have to perform, and it's very fragile, and you can use this nodal like a vein, and then you can inject to be sure that you don't have a problem of perforation problem also because it's like a fragile vessel. We test them in biomechanical test. If you test the suture, if the suture is not good, you will have a lot of, you can see here, liquid outside. A second model, level 2, is this one with electric system, and especially if you are not precise in your gesture. And it's also a synthetic model tube, less than 1 millimeter of diameter. So it's like arterial model for microsurgery and anastomosis. And we have with microscope model of 3D vision, because maybe in the future the classical microscope will disappear. So they have to train with this kind of new microscope. And also we develop with a startup in Strasbourg numeric model. You have here the micro clock. It's a very useful test for surgeon and for training, because we publish an article. If you have more than 3 minutes to do the exercise, it means that you have again to go to the microsurgery lab and to train again. It's very important to have evaluation, because you have to compare different kind of teaching, and also if you want to publish, you have to standardize what you will evaluate with your students. And of course, don't forget the digital tools. We can use e-learning and to show videos or documents for students. And what is also very important, and then after learning for senior surgeon, is also to have forums and to discuss like we do tonight, and to share different experiences or new techniques of teaching. It's something new, and it's also a good way to progress. And also a new way to teach and to learn is the deliberate practice. It means that you will practice, but you will also the teacher will after look with a video what the student did, then like a coach discuss what he will have to improve, and then we will do again, and again we will make a video. And it's also a new way to progress for learning microsurgery. So to conclude, now we have a lot of new tools. We have simulators. We have to learn a little bit robotic, microsurgery, and also to use a new microscope. But we have some logs because the animal models probably will disappear. And we have also a problem if we have too much videos, too much course on internet. I think we have a lot of things to do, and the teaching, the education will continue to progress and to be modified. Thank you.
Thank you very much, Sybille, for this excellent lecture on education in microsurgery. So you have highlighted not only the technical aspect, but also the importance of structured training, mentorship, and innovation in teaching methods. So I think especially microsurgery is one of the fields which are really difficult to show to people because you really have to do it by yourself. But I think your talk really has given us inspiring insight and practical ideas. From my perspective, I didn't know of these noodles, which I find is a really good idea. We always use just chicken legs, but yeah. But I'm sure we will have some questions from the Q&A, which we can.
So, Sybille, what are the current indications for robotic assistance in microsurgery? Is it just that you have a robot available, or?
Yeah, so you have a different problem. Yes, the robot is not available everywhere. I know, and it's a big problem. And yes, you have some indication. Of course, you don't have to use the robot for every procedure. But I show you a procedure of intercostal graft, and of course for the patient you have a small incision. It's mini-invasive techniques, and it's very convenient for the patient. And so yes, for the brachial plexus, it's something important because you can so manage the suture with mini-invasive approach. And also in the future, if you have more robots, you can do telemicrosurgery. You can imagine to have a surgeon in Strasbourg, a microsurgeon in Strasbourg, and an orthopedic surgeon in another city who needs just to suture the nerve. And so he will do everything. And for the nerve, he will put the robot, and the microsurgeon can perform the suture from another city, for example.
Do your residents have a formal technical assessment when preparing for the hand surgery diploma?
It's two different diploma in France. You have a diploma of hand surgery, and you have a diploma of microsurgery. It's two different. But then, when they want to become a surgeon, they have to pass the two diploma.
And for what else do you use the robot also for just a normal traumatic nerve lesion, or do you use it only in special indication, or do you use it now like every day?
In Strasbourg, no, in Strasbourg we use in the past for specific indication, especially for brachial plexus lesion. It was a role model of Da Vinci. I show you the Simani we don't have in Strasbourg. So this one is smaller, and this one you can use for the classic nerve suture, collateral nerve suture. But we don't have yet in Strasbourg. You have in Reims, in Paris.
Okay. Okay, then we have another question. What is the minimum to pass the microsurgery diploma? So what do you have to do? Or how long does it take for is it 1 year or 2 years?
Now, normally it's 1 year, but in France it's not a homogeneous diploma. For example, in Strasbourg, I have 2 levels. I have level 1 with non-living models and for 1 year, and then I have level 2 for animals model, because I have a problem with animal administration. And so I used to make immersion. So the students will perform microsurgery in immersion. So during 2 weeks, 8 or 10 days by day. But in some other university, they did totally differently. It means that the student will come once a week or once each 2 weeks to the microsurgery lab to train on animals. We have a group, a national group. We try to do the same in the future, but it's not everywhere the same way to teach. But at the end, we have, of course, to evaluate the nerve suture, the vascular suture, because it's mainly it's the practice training. And at the end, we evaluate and we say it's okay or not, of course.
So I think Germain is struggling to join. So shall we carry on with Kursat Erdogan's talk next, Sybille?
Okay, so Germain is from Luxembourg.
I don't think he can. I don't think he can join at the moment. So we'll maybe carry on with Kursat's talk while we try to get him online.
So the Dr. Erdogan is a surgeon in my department in Strasbourg University. And we will talk about nerve tube for nerve regeneration.
I'm sorry, I had a
Perfect.
Okay, you're
Yeah,
muted.
you're muted, Dr. Erdogan.
Sorry.
Perfect.
Do you hear me?
Do you want to start your talk? So
Yes,
Dr.
of
Erdogan
course.
is presenting some unpublished data. So we would ask you to respect the confidentiality of that data. So it's very interesting to hear, hot off the press, but they need to publish it before it can be shared more widely.
Yeah, where is my presentation? I just okay, it's just here. Okay, sorry. It's my turn.
We can see your slides and we can hear you.
Are you good? Can you hear me?
All good.
Okay. So hello everyone. Thank you, Professor Facca, for the introduction and your presentation. And I'm here. To present my topic called Nervix for nerve repair. This topic is important because peripheral nerve injuries are common and often lead to. Sorry, what's happening? Okay. And often lead to serious disability. The loss of sensation or movement in the finger or hand can impair daily activities and work. Even with surgery, recovery is frequently incomplete. So our goal as surgeon is not to only repair the nerve, but also to protect and enhance regeneration so patients regain function. So To begin, we will talk about what actually happens when a nerve is injured. When a nerve is cut, a series of events called Wallerian degenerations kicks in. The distal segment quickly breaks down, and within a day or two, the distal nerve fibers degenerate and lose function. The Schwann cells start clearing out debris, working alongside macrophage to digest the damaged tissue. After a few days, those same Schwann cells line up to form the guiding path called the band of Bündner that will help new axons sprout and find their way. The nerve fiber on the proximal side starts extending new axonal sprouts, trying to cross the injury gap. Nerve fibers grow slowly, about 1 millimeter per day on average, if conditions are good, and remyelination and recovery may happen. But this process is slow, and recovery is often incomplete, especially if the gap is too long. The gold standard is still direct epidural suture if there is no gap and no tension. When direct suture is impossible because the gap is too large, the solution is autologous nerve graft. We take a segment of another nerve from the patient, often the sural nerve or the lateral antebrachial cutaneous nerve, and use that as a bridge to reconnect the two ends. But they both have limitations, specifically for the autograft, as the donor site morbidity and the limited availability. Even direct suture repairs have their issues. In fact, one review of hundreds of digital nerve repairs found that about 38% of cases ended up with poor sensory recovery after direct repair. For that, surgeons have been searching for ways to improve nerve repair outcomes and to overcome these limitations. One solution that emerged is the use of nerve conduits. A nerve conduit is essentially a tube or sheath that bridges the gap between the two nerve ends. Early conduits were often made of silicone or other non-degradable materials, but they were abandoned because they created foreign body reactions. There are several types of conduits categorized by material. First, the synthetic conduits, which are made from polymers like PGA or PLA. We also have the natural biomaterial conduits, which include those made from collagen, chitosan, and there are also biological conduits taken from the patient tissue, like using a segment of vein or a rolled piece of muscle as an autologous conduit. The main idea with conduits is to provide a bridge when direct suture would be too tight and to avoid also an autograft donor site. Conduits prevent external scar tissue from invading the gap and guide axons to the other side. They're generally considered an acceptable approach for sensory nerve gaps up to 20 to 30 millimeter. Using a conduit has some clear benefits. We avoid sacrificing a donor nerve, and conduits can also reduce neuromalformation by capping the nerve ends in a chamber and preventing axons from spilling into surrounding tissue. The typical indication for a conduit is a digital nerve or other sensory nerve gap, usually in the hand, up to 2 to 3 centimeters, where direct repair is not possible and the gap isn't too large. So now let's take a look at a few case studies I have found from the literature to see how nerve conduits compare to traditional repairs. First, we have this systematic review by Braga Silva et al. We looked at the use of nerve conduits in peripheral nerve injuries. They analyzed 27 studies with other 1,000 patients in total, and these included randomized trials and case series using various types of tubes. The overall finding was that outcomes with conduits were comparable to those of direct suture or grafting in terms of functional recovery, with the recovery rates exceeding 80% in the conduit treating injuries. Their conclusion was that using nerve conduits is preferable over primary suture or autograft in appropriate cases, since you avoid tension and donor morbidity while still getting good results. However, they also noted that synthetic conduits were associated with more complications, like conduit extrusion, infection, or excessive scarring. Next study is a meta-analysis by Narayan and al. Who examined outcomes of conduit versus direct suture repair, focusing on sensory nerves. They found that repairing nerves with conduits was significantly more effective than direct suture for sensory recovery. The conclusion was that using a conduit is a safe and more efficacious method for sensory nerve repair compared to a tensioned direct suture. Lace et al. In 2024 published a meta-analysis comparing direct repair with connector-assisted repair and at the standard meaningful recovery level, which means S3 or better sensory score, 96% of patients treated with a conduit achieved that versus 81% with direct suture. Moreover, they found a stark contrast in cold intolerance. Nearly 46% of patients who had traditional direct repairs reported cold hypersensitivity in the affected hand, whereas only 11% of those with connector-assisted repairs did. There was no increase in neuroma formation or chronic pain with using conduits, and the revision surgery rate was essentially zero in both groups. The authors conclude that these conduits significantly improve sensory outcomes and patient comfort, supporting their use over direct repair for many cases. Finally, we have an overview by McMorrow and al. Who provided the state-of-the-art perspective on nerve gap management. They repeated that autografting is still the widely used gold standard for large gaps, but it has clear drawbacks like limited donors, size mismatch, or donor size morbidity. The nerve conduits, on the other hand, have gained attention in recent years. McMorrow's review noted that while conduit outcomes in sensory nerves up to 3 centimeters are generally similar to grafts, there is still a gap in outcomes when it comes to longer defects or motor function recovery. Overall, the literature is painting a positive picture for nerve conduits. They are a valid alternative to grafts in many cases and can even improve certain outcomes like reducing neuroma or cold sensitivity. So now let me introduce Nervix. So what is Nervix? It is a biological nerve conduit made from processed human umbilical vessel. It is made from human umbilical cord vessel, specifically a vein in most of the cases, and this vein is then turned inside out and processed to serve as a nerve guide. By inverting it, the basement membrane side of the vessel is exposed, which has a good micro architecture for cells to attach, and the smoother side with the all of the elements is inside. So the vessel then is decellularized and freeze-dried to make it safe and shelf stable. The Nervix has two indications. First, to bridge small nerve gaps, usually less than 2 centimeters. And the second indication is the wrapping and protection of the nerve after direct suture in order to limit scar tissue, to reduce the fascicle extrusion and create a safer environment for regeneration. Now I will show you a little video of the surgical technique. Here we see a digital nerve that has been directly sutured end-to-end with two epiperineural stitches without any tension. Now we wrap this repair site with a conduit to protect it. And to do this, we first opened the tube by making a longitudinal cut along its length, turning it into a flat sheet. Next, we gently wrap this sheet around the repaired nerve, covering the suture site completely. Finally, the conduit is closed around the nerve by suturing it to itself with one anchoring stitch placed at the proximal and another one at the distal end of the repair. This secures the Nervix wrapping in place around the nerve and provide an added protective sleeve over the suture site. So the first published study about the Nervix is this study published by Erdogan, which presents a multicenter study with 23 patients with proper digital nerve section, with an average nerve gap about 6 millimeter, and they underwent surgical repair using this conduit. The patients were followed for 10 months on average, and the primary focus was on the recovery of sensation in the affected fingers. By the final follow-up, patients' finger sensation improved significantly, with the S2PD improved by about 8.5 millimeter, and approximately 83% of the injured nerves recovered complete innervation by the end of the study period. Secondary measures also showed positive trends like pain and other nerve-related symptoms, such as cold sensitivity or numbness. And hand function and quality of life scores improved as well, and no safety issue or device-related complications were reported with the use of this conduit. What about our series? So in Strasbourg, we reviewed our own experience using the Nervix, and we conducted a retrospective case series involving 32 cases of palmar digital nerve injuries. In each case, the injured digital nerve was repaired with direct suture without tension, and then the Nervix conduit was used in a wrapping technique around the repair site, as I showed just before. And all patients were followed for 1 year after surgery, with regular assessments of their sensory recovery, pain levels, and hand function over time. By the last follow-up, the average S2PD among these patients was about 8.3 millimeters. 21 nerve repairs resulted in no pain at all. 8 had only mild pain, and 3 patients reported moderate pain. None of the patients experienced a severe pain during follow-up. The quick dash disability scores ranged from 0 to 11, and throughout the follow-up period, we did not observe any complications related to the Nervix conduit. So in conclusion, we can say that repairing peripheral nerves in the hand remains a challenging task. When a nerve defect is too long to bring the ends together without tension, if the gap is more than 2 centimeters, the autologous nerve graft is still considered as the gold standard solution. And this traditional approach works well for bridging longer gaps despite its drawbacks. For shorter nerve gaps, nerve conduits have emerged as a promising alternative. The biological conduits like the Nervix offer a new option to support nerve healing across small gaps without the need for a graft. Early clinical evidence is positive, showing that these conduits can yield good sensory recovery and functional outcomes in digital nerve repair. Our own case series demonstrated encouraging results at the 1-year mark with excellent sensory return and minimal pain in our patients. While these initial outcomes are promising, continued research and longer-term follow-up will be important to confirm the long-term benefits of conduit-assisted nerve repair. And the goal is to improve nerve healing for the patients, and every new tool or technique brings us a step closer to better recovery after nerve injuries. Thank you for your attention.
So, Dr. Erdogan, thank you very much for a great talk. And this is this is promotion for Strasbourg, so we're starting early.
Yeah, also promotional for our FESSH Congress to 2028 in Strasbourg.
I'll be there.
You're all welcome.
As the co-chair, there are 1 or 2 questions, but I can ask a question first. So 2 questions. One is, how much does it cost?
It depends for the country, of course, but in France, the cost of one conduit is about 1,000 euro.
And the second question is, in a finger, you get crossover from the other nerve. So how can you be sure that the sensory recovery is not crossover from the other side?
Actually, that's a good question. I'm not sure to be able to answer this.
Hey, can I also ask a question, or you want to answer, Jonathan?
You can think about it and see if you can come up with an answer by the end of the webinar. Elisabeth, what's your question?
Is this only available in one size, only for the digital nerves, or is it also for bigger nerves?
They have different sizes. They actually have three sizes. It's a 2 millimeter diameter, 2, 3, and 5 millimeter. So we can also use it for the bigger nerve like the median nerve in its distal part, and they also have different length of the conduit, which starts with 1 centimeter, and 2 and 3.
That might be a cleaner test for a bigger nerve. There are questions about whether there's a difference between autograft and allograft for long defects.
Allografts?
Or
actually, we are not able to use the allografts in France.
Okay. Elisabeth,
so
do you have an answer to that? Is there anything in the literature? I don't know.
I think, yeah, we just had some guidelines for the German society, or for the German national guidelines, and we looked through the literature, and it says that the best outcome still has the autograft. So in any kind of systematic reviews, the autograft always was had better results than the allografts.
There's also a question about reversed umbilical cord vein. Presumably that's an allograft.
I have never experienced the inverted umbilical cord vein.
Okay. And what's the longest gap that you can repair with a Nervix?
As I said, it's in every study I read, it's the same gap, approximately 2 to 3 centimeters, the gap.
Okay, so that's quite a long gap.
And if you would choose for an autograft for a digital nerve, which is your favorite nerve graft for a digital nerve?
I used to take a few times the PIN.
Okay.
Okay.
Any other
Well,
comments from the panelists? Guillaume or Sybille, do you want to
I have a question for
comment
you.
on it?
Yeah. Did you experience or observed kind of foreign body granulomas you can have when the conduits don't resolve at all, or is there inflammation around the scar, or this kind of postoperative complication, or
Not at all.
not at all? Okay.
Actually, we're specifically looking at this. It's one of the data we're collecting, and we didn't find any complication like you said.
Because I
But
think for the Shituzan, I don't know if you know this, they were the first 1-year follow-up studies. They were really praising this new nerve conduit, and they have really great results. And then they did a longer follow-up, and then the opinion completely changed. So they found out that they have a lot of granuloma and a lot of during this degeneration process, that a lot of that conduits have to take them out again, because people were really, really unhappy. Although the first year it was like really superb results. So we're really interested in the long-term follow-up of yours.
so we look forward to Paris
Yes.
next year, Dr. Erdogan, when we can have the
But-
longer term results.
Of course,
But
thank you.
I think the difference is that it results in 8 weeks. So this is
Okay.
really a short time, if this is really true.
I can confirm this information because I had to take had to do a second look for a patient it was about 2 months after the surgery, and the conduit was resorbing, and I guess yes, in a few weeks or in a month ago after, maybe I couldn't find anything.
It's interesting.
So I'm delighted to say that Dr. Pomares has been able to overcome the IT gremlins and has moved from an observer to a participant. So welcome, Dr. Pomares. Thank you for your persistence in being able to log in. We look forward to hearing your talk.
Hello,
Can you turn your camera on?
Yes, I try.
Yes,
Okay.
we can see you, we can hear you. Maybe see if you can share your screen and then you can start.
Okay. Is it okay?
No, there's a green share button at the bottom of the screen in the middle, with an upgoing arrow. Can you see?
Yes. Okay, I think it's okay.
Oui, parfait. C'est parti.
Okay. Apologize for my connection problem, and please excuse me in advance. I'm on duty and the phone may ring. Okay. 3-2 transfer in 25. Thumb reconstruction is the most common surgical indication. Don't forget Harry Bernke's monkey. This technique was performed on the thumb. Fortunately, the thumb is not the only indication for two-to-hand transfer. Harvesting. The harvesting follows the same principle regardless of the type of transfer. In this case, the thumb dimensions are mapped into the first toe to perform a tailored transfer. The blood supply is provided by the vessels of the first metatarsal space, particularly the dorsal artery when it presents. This dorsal approach allows harvesting of the neurovascular pedicle. After that, it's just a matter of putting the pieces back together. It's like a Lego techniques. Okay, now 3 cases. The first case, it's a 70-year-old female with a complete degloving injury of the middle fingers. After treatment and exploration, continuity of the both pedicles is preserved up to the basis of the last phalanx of the first phalanx. The tendons, extensors, flexors are intact. In this case, I consider this to be a transfer option from the second toe. The harvesting follows the same rules, a dorsal approach, but toe volume being smaller than the fingers. A skin graft with matriderm on matriderm is always needed. And the result after 6 months, she has a complete bending and extension. Second case, this is a young man with a burn of the palmar side of the hand, of the surface of the hand, with occurred in early childhood. He presents with a major contractures of the third and the fourth fingers. Patient request is only the contractures. I performed an excision of the palmar bones on the D3 and D4 with a plasty, with a easy plasty on the second and the fifth fingers. That plasty proved insufficient in my experience for the D3 and the D4. In this case, we reversed a bilobed flap from the first and the second toes. One technical trick during the flap positioning is to route the flap through the palmar incision. The result is not perfect aesthetically, but it allows a full finger extension and bending. And the last case, but not the least, a complete amputation of the first ray at the basis of the first metacarpal bone. I try a revascularization of the fragments, but 3 days later, we had to remove due to a microsurgical failure. Obviously, this is an excellent indication for politicization, for index finger politicization, but the patient formally refused the politicization. A 2-stage reconstruction was proposed, with the first involving reconstruction use a trifoliate scapular flap, bone and skin, in order to reconstruct the first metacarpal bone and the functional skin unities, the first waves, the dorsal side and the palmar side. At this stage, the job is done, the procedure is complete, with a simple transfer according to Morrison, a wraparound Morrison. This strategy allows the patient to return at this previous job. We observe some dystrophy, some nails dystrophy. It's just a transient and will be resolved in a few months. It was a hard pictures. Okay, for the future directions, in my opinion, more attention should be paid for the donor side in order to minimize the sequelae and the healing. It's often more than 2 months for the healing. EFORT should be also focused on the method of osteosynthesis for the transfers to allow a early rehabilitation. And probably the last indication, the last surgical indication, that is the commissural transfer remain, and I know to deserve a recognized place in therapeutic arsenal. Thank you. Thank you for everything.
Thank you very much, Germain. And many thanks for presenting the solution in these complex injuries. So I think we have some questions. Oh no, not yet in the audience.
I'm too fast, probably.
I think we have some cases, Guillaume, or Jonathan, or anyone else has a question from the panelist. Maybe I have a question. When you have this situation with your patient lost one of the digits, and you start to explain him what your plan is, that you want to take a toe.
Yeah, it's necessary.
Yeah,
Always
but
I
I mean,
present
do
some.
you know the reaction of the patients at first sight? They always say, "Oh no, how does it look like when I have a toe on my thumb or whatever?"
To
Or are
explain
people-
this procedure, the most important is the pictures. To propose this transfer, to transfer, you have to have a lot of pictures about the
And
hand,
convinced.
the results of the hand, and the feet. It's really important. Every time, the most point is the pictures in my consultation.
I agree. Yes, of course. You can just convince people with your good results. Okay. Guillaume, you want to start present the cases?
Yes, of course. I think we have two questions from the audience, but we can present the cases and answer the question afterwards, as you want.
Oh, yeah, okay, you're right. So one question is, when we can do toe transfer post-trauma? So do you do it immediately, or do you say just wait for 6 months until the soft tissue has recovered, or how is your procedure?
It's a good and difficult question. Probably the main objective is to restore the psychological aspect of the patient. It's impossible to realize in emergency a transfer when the patient is, I don't have exactly the good expression, but psychological aspect of the patient is really important in this surgery. And probably most important than the tissue.
So there's no especially a specific time window where you say, I always wait 2 weeks. You also do it like 3 days
we have
after?
to, I present 2 cases in emergency, okay? The lady, it was 2 or 3 days after the injury, and the last cases, it was less than 1 week. But sometimes I wait many months, 1 year, and for few patients, never. Not for functional reasons, but for just psychological reasons.
Okay, one last question from the audience. With the toe transplant surgery, what is the learning curve? And what is your failure rate? Maybe you can be honest. I mean,
A Morrison flap is not really difficult, okay? We observe, you have a good teaching, but it's not really difficult. Some transfer is really difficult. The MTP joint probably is the most difficult. We have many points. The transfer, the type of transfer, the MTP joint is difficult, and the situation on the hand. When you have big blast, an example, a blast, we have a lot of lesion on the vessels, and sometimes you need to realize some bypass and a long bypass. It's not for me, the most difficult is not the technique, it's just the organization, the planification of the surgery.
Okay, Guillaume, I think now we go to the cases.
Okay, so I have two cases. Okay, can you see my slide?
Yes, we can see and we can hear you, so we're all good.
Okay, so I don't know if we are all orthopedic surgeon here, maybe it could be plastic surgeon, but it's about bony traumatism, but we'll see at the end that there is a nerve lesion. So you have 54 years old male with a very oh, sorry, what's happening? Okay.
Yeah, that's advanced.
So a very comminuted fracture, it's kind of nightmare, open fracture. And as you can see, you have here kind of a spike, bony spike at the palmar aspect of the wrist. And you can see how it has been managed with external fixator and quite good reduction despite the really heavy comminuted traumatism. But you can have a bad surprise with the median nerve, which is almost totally divided, cut, and with a quite important gap. So probably the gap is, I think, linked to the edema of maybe flexors, or I don't know, but there is a huge gap. And so what's your approach? So
How long are we after the injury?
it's in emergency.
In emergency.
And you
In
cannot
emergency.
mobilize.
Sorry?
So you cannot mobilize, right? It's really a gap.
Yeah.
Otherwise, it would be tension suture.
Yeah, it's difficult to put the two extremities together, and you have the nerve lesion. So
I
what do
would go
you
for sural graft.
Psoriasis, okay. So neutrograft.
So yeah, so I would see if I could adjust the fixator to get a more flexed wrist, see if that helped. If I would consider shortening the bone. So I can't remember, it looked pretty smashed. So it may be that you could shorten the radius a little with the expectation you would then need to shorten the ulna later. But so not shorten it with a saw, but just because a direct repair would be better. But if that was not possible, then I agree with Elisabeth. I'd do a sural nerve graft, a cable graft.
It's interesting because I think prior to the operation, you wouldn't have expected this. So you
No.
and then you didn't have a conformed consent form for the patient to take the sural graft.
Yes.
No, I don't think anybody could argue it wasn't in the patient's best interest, though. But you would expect the hand to have been a little numb pre-op, so that might be.
That's true.
Because you can get jump conduction, but not across 2 centimeters.
But just to ask then, the nerve conduits, are they also for motor nerves or only for sensory nerves?
Both.
Both. Okay.
They have the bad reputation to be not as good as the autografts, but they can also be used for this kind of lesions.
So would you have chosen for Nervix?
Actually, it's my case.
Kursat
And,
case. So we can expect that he use a conduit, yes, Nervix. And what about the outcomes? Do you know what it happened finally about the outcome of this patient, Kursat?
yeah, I saw the patient 2 months ago, and I shared with you the table of the clinical examination. Yeah, and at 6 months we had an improvement of the sensitivity, but fortunately the motor recovery is not well.
Is there any function in APB?
The APB is not functional. No.
But you said it was 2 months after.
No, we have this. The last results are for 6 months
6
after the
months.
surgery.
Yeah.
6
Yeah.
months.
6 months.
And just a precision, I will do a secondary surgery for the wrist because we had a secondary displacement of the fracture, and I will see the Nervix and probably take some pictures to show if it's still there or if it's resolved.
Sure.
So if it resolves in 8 weeks and the nerve grows 1 millimeter per day, then 2.5 centimeters is the maximum possible, so that the conduit is still there before it dissolves, or not? Before.
In the well, in the papers, it says that it's if we think like this, it shouldn't be there because it resolves itself in 8 to 12 weeks.
So it will be interesting to see what you find when you.
I will share the photos.
I think also for the time of resorption, the size, the length, and the will be important. I think maybe with small tubes, resorption will be shorter, because this one is a long, it's a large one tube. It's not a small tube.
Big diameter, yeah.
Big diameter was how much?
It was a 5 millimeter tube, the biggest one.
You have more materials around. Yeah.
Guillaume, shall we carry on?
Yeah, sure. I have a second case. So it's a case from Germain. So a man, 75, right-handed, a very huge accident, a saw accident, with very serious lesions. Interesting, the second digits and the second and third digits with totally destroyed MCP joints with bone loss of the first phalanx with the extensor divided, but and it is important to notice that the neurovascular bundles and flexors are intact. And about the third digit, PIP joint and second phalanx totally destroyed, and also flexors and neurovascular bundle divided with loss of substance. So here's a picture of the traumatism. So as you can see, you have here destruction of the MCP joint of the second ray, digital ray, with loss of substance also of the first phalanx, but vascularized digits. And on the other hand, you have on the third digit destruction, which is more distal with no vascularization. So
Do you have an X-ray?
no X-ray. I'm sorry, no X-ray.
So I think in a 75-year-old, the chance of getting a useful middle finger is not very high. So I think I would try and use what I could from the middle finger to reconstruct a functioning index. And I thought that before I had a flash preview of the answer.
Yes, sorry.
Elisabeth?
Yeah,
Sorry?
I think age is one important aspect which we have to discuss. I mean, it's the right hand, but still, I think the most important function is to grasp.
Yeah.
So, and you can do it with 4 fingers. You just have to have an opposition. So, I also would agree with Jonathan. I would use the tissue to cover the defect on the dorsal hand and try to fix the the vascular third finger.
So, okay.
So thorough debridement, washout, stabilize the skeleton, and then if you're going to use the spare parts, there's some urgency. You have to do the reconstruction at the time. You can't wait a day or two to see if it's clean. Unless you can park the digit, and I don't have the skills to park the digit.
So the treatment option is from Germain, so a very skilled surgeon. So he made a translocation of the second digit, vascularized digits on the third, and with proximal osteotomy removal of the second metacarpal just to open the first web, and made the ORIF of the around the first phalanx, reconstruction of the extensor mechanism, and reattachment of the first dorsal interosseous muscle. And here we can see the first stage with the osteotomy, and keep it vascularized here, removal of the part which is devascularized, and make the stabilization, bony stabilization with 2 K-wires, and a pretty good reconstruction.
Very nice.
Outstanding.
Why K-wires, not a plate?
Germain?
It's
Can
more
you-
it's more easy and fast.
Or a screw,
Yeah,
or
a
interbedded
cannulated
screw.
screw. Yeah.
And you can remove the wires.
Sure.
That is the main reasons for me.
Okay. Very nice.
Very
Very
nice.
good.
Yeah, very elegant.
Excellent.
Elisabeth, I think you have cases too.
I think we have one last case. So I'm going to share my screen. Just wait a second.
I need to stop to share. Yeah.
Mhm. Okay, so it was a 2-year-old, and unfortunately, he put his right hand into a meat mincer. So this was the hand which, or the amputate, which we were seen in the emergency department, and this was the forearm. So we tried to replant 3 digits, also with K-wires and the microvascular suture, because the other 2 were not able to transplant, and we were thinking of making like a grasping function. And unfortunately, the smallest digit were not well blood supplied after, I think, one week. We were just still watching how it how it get along, but then at the end we had to remove it. So at the end, he had this this wrist or this fingers which were quite well vascularized. And now the question is to our specialist, Germain. So this is now half a year. The family, I mean, it was a psychological issue as well, that the kid has to, we're able to look at his hand again and to accept that this is this right hand. But now he gets quite good along with this situation. What would you recommend to do? What would you offer do you have any ideas what you could offer to improve the function to the small child boy?
I don't listen, but what is the function and the
It's just
psychological effects?
it's just I mean it's just a bit tiny movements.
Tiny movements.
But I think he can, as you see, he can open and close a bit.
Mhm.
So I mean I cannot give you any like power measurements, but
And what about the sensitivity? The skin sensitivity is still functional or not, or is it tingling or?
I mean, he's 2.5, so it's not very
Yes.
easy to
It's not
examine
easy.
him and to ask him, but he has some sensitivity.
Okay.
Mhm. Mhm.
So there's some flexor and extension function.
Yes, but I think
And
I'm not sure if he can move the joints separately.
Okay.
and there's normal sweating.
I cannot answer.
Let's say yes.
Yes.
Um,
I mean, they were replanted, and every structure, the nerves were sutures, and the tendons, and like all structures which you usually normally do.
But at 2 years old, the nerve regeneration,
It's
even
very
if you have
good.
two level of section, is very good. Yes.
Exactly.
Mhm.
I think this is not an issue. I think it's just thinking of toe transfer. We have already mentioned this, but at the moment, the family is just happy to get it into their daily life and that the kid returns to kindergarten and stuff. But for long term, would you go for toe transfer or how? Because he has this 2 fingers to grasp.
Yes. 2 and 3 in the third term.
Any ideas?
what bone is there in the carpus? Do we know?
I mean, at this age, you mean
So what is there between the bottom of the digits and the radius? Is there a cartilage? Could we get an MR to see?
an MRI?
Yeah. Because
Yeah.
there's not much to see on the X-ray, but it may just be because it's not ossified.
I think that's the reason actually,
Mm-hmm.
because the gap is still existing as normal, I think.
Yeah.
So I think the wrist bones in this age, I mean, the scaphoid you can assume here. But Germain, would you say this is a candidate for a toe transfer, or would you just leave it as it is, or put some prosthesis, some myoelectric ones, or something like this?
It's a difficult questions. The main problem for me is the carpus. The carpus.
So we wait until the carpal bones were developed, do an MRI, see how he gets along, and then because I mean, on the other hand, prostheses nowadays are also quite a good option. But then these 2 fingers are in a way, I guess.
Yeah, yeah.
2 years old is the moment for many surgical options.
Okay.
But I don't know with the X-ray.
If you didn't want to do an MRI, you could maybe do an arthrogram. If you just put a little dye in the wrist, it will show the outline of the bones if there are some.
Good idea, yeah. Okay.
And maybe if you don't do to transfer, also you can improve the pinch to put flap between the 2 fingers
To make it more wide.
maybe.
Okay.
Also another.
Ellie, do you have one more case for us?
Yeah, the other one is just a vascular malformation. We can just go quickly, or we
have 5 minutes, so
okay. Then this was a guy presented with a swelling. He was 21 years old in his left hand, Then he had also some pain. Then we did some MRI, and we were seeing that, I make it a bit slower, that this swelling was an aneurysma of the third digital artery. As you see now in the first attempt, the artery is not well vascularized, the third one, and now it comes a bit later. But the fingers,
yeah.
I mean, the
Yeah.
third and the fourth one were vascularized from the other half of from the other artery. And yeah, later on it comes a reflow from a backflow from the digital artery from flow. So this was the MRI result, and they said it was a 7 millimeter aneurysm in this digital artery, which you can see here a bit, and the swelling. So what would you do? What would you recommend the patient? There was no, his problem was the pain and the swelling. It was not a problem of vascularity of the digits. They were at any time they were full vascularized.
So the common artery has an aneurysm, but there's an intact artery on each side of the finger, yeah? Of the other finger. Okay.
So would you do some microsurgery, or would you just put some clamps on it and just ligate it? Would you do some vein reconstruction?
A graft we can remove the aneurysm and put a vein from forearm.
Yeah, very young patient. Very young patient. Yeah.
The problem was that the vascularity of the connection between the radial and ulnar artery was also not very well perfused, as you see here.
Yeah.
So because we were thinking of doing also vein graft, why not? I mean, it's easy if it's only like 2 centimeters or something, but the proximal anastomosis would have been in a field where you had to do a T shape or something. So so that was another technical observation. So
maybe you can use because you have a collateral artery from the interdigital one between index and major, because maybe you can make the graft from distal part, of course, for the finger, but we have a collateral. You can see the collateral.
exactly, yeah.
It's not typical, but
and the other thing is he had a van Willebrand syndrome. So he was missing factor 8. So it's also he had some and he had some prolonged blood thickening also. So he also has some vascular issues on top. So
there's a vote for gel foam embolization. The slight risk with that would be if you end up embolizing something you don't want to.
Exactly.
And surgically, this would be quite easy to remove. So just before we close, we have a question for I think Germain's finger translocation. What's the range of motion?
Nearly complete. I have the picture if you want. I can show you. Guillaume,
Oui.
do you have the picture at 6 months?
No, I haven't.
Okay,
I
I
think
can show you.
it was not in the PPT you sent me.
Okay, I can show you. It will be. Okay, just give me a few seconds.
Does anyone have experience with gel foam embolization?
It was
We,
on the chat. Yeah.
we have
The
radiology,
radiologists do it.
Huh?
yes, in a hospital, but not.
Okay, interesting.
But it's something surprising. The radiologists they could be very, very precise. And I have macrodactyly to operate, and we decide to perform the day before surgery embolization of macrodactyly, and it was very precise in the middle of first phalanx, and some radiologists have a lot of experience.
So while we're waiting, Elisabeth, do you want to share the details of the next webinar?
Of course. The next webinar will take place on the 2nd of October, and it will be held by the Irish Hand Surgery Society, and the topics will be about spasticity and thoracic outlet syndrome. So also a very interesting field of our specialty. So I thank you very much for the French Society. We're still waiting for Germain's great results.
Can you find it,
Okay,
Germain?
yes. Okay, I'm here.
Yeah.
Okay.
Just show us what microsurgery can do and how the function.
Hopla.
Okay.
Do you see
Wow,
the pictures?
that's
Yes,
amazing.
we do. So we finished the webinar on a high note, which is always good.
It's not so bad.
Great.
No, it's
Yeah.
excellent. A nice cosmetic, nice function. Very good.
Very good. Yeah.
Okay, thank you everyone for your attendance and also the participants. I hope you have learned a lot, especially from the different new techniques. And that's from our side. And yeah, we hope to see you in 4 weeks' time. And we wish you all a good night.
Thank you.
Thank you. Bye-bye.
Thank you very much, France.
Thank you, Jonathan.
Right.
Elisabeth.
See you 2028 in Strasbourg.
France, 10
Thank you
points.
very much.
10 points for France.
Bye-bye.
Ciao.
Thank you. Bye.